right. Again, welcome everybody to Allscripts MyWay for OBGYN. My name is Jill Dilligan. I will be your demo guide today. We'll get this started with a quick PowerPoint presentation just to give you a brief orientation of what you're about to see before we jump into the live application. If you're not currently in contact with one of our Allscripts account executives or an Allscripts partner of ours, and you like what you see today and want to explore the solution in further detail, please make sure you contact the toll-free number you see on the screen right now and choose option 1. That will get you in contact with one of our solutions consultants who can further investigate with you what your questions may be, and they can also pair you up with one of our partners to take you down that path of exploration with this application. I'll be happy to bring that number up again during the open Q&A session if by chance you did not have a pen and paper to write that down right now. What to expect for today? I'm going to go ahead and kick this off with talking about the key differentiators. What makes this product different out there in the market? We'll also take a look at the end result. We'll show you some sample OB reports and a chart note. Then when I get into the live application demo, I'm going to briefly talk about that main login screen and then cover 2 clinical scenarios. Both scenarios are under the premise that the medical assistant has already roomed the patient, taken the chief complaint and vitals, verified patient's medical history, and both situations I will be demoing as though I'm the provider walking into the room and picking up from there. Once I conclude those 2 clinical scenarios, I'll open it up to Q&A. What not to expect today? Although MyWay is a fully integrated practice management and EHR, I will not be showcasing the front desk scheduling, patient demographics, billing, nor the reporting related to billing in today's demonstration. While if you'd like to ask questions at the end, I'm more than happy to answer how best I can. Just please do not expect to show me, as I have not prepared to show you any of the billing today. We do have a billing-only webinar, and we found sometimes it's 2 different audiences that need to attend that. This is definitely geared towards the clinical side, the physician side. I also will not be able to address contract-related Q&A nor pricing. Again, I encourage you to follow up with your Allscripts partner that you're already working with or contact our solutions consultant to talk about those type of items. To kick it off with some of the key differentiators, MyWay actually has what's called adaptive learning. What does adaptive learning look like, or what does that mean? It just means it starts to recognize your habits. It remembers everything that you document and presents it back to you in a most frequently used list. The screenshot that you see right now is actually taken from my own demo database based upon my OBGYN demos. Notice here that all of these are based upon or related to OB gynecological problems. It will automatically keep track of up to your top 50, and it's a dynamic list. It always rotates based on your usage and how frequently you use them. Again, you don't have to take the steps to tell the system to remember this list for you. It does it automatically, which I think is pretty unique out there in the market. If you take a look at this diagnosis listing, the same thing happens here as well. So it's not just at the chief complaint area, it's also in the diagnosis tab. And what's even more unique about the diagnosis tab is the more often you diagnose a patient with something, and not just a specific patient, but over your entire patient population, it will actually float up towards the top. What that tells me is, if you see here, the vaginitis, that's what I document on most. If you look over here, my routine gynecological exam, that's what I've documented on least out of my up to top 50 diagnosis codes. Furthermore, we actually do build out this list to match your super bill or your encounter form. Everything that you see over here in this side today is actually built from my demo database. But again, this will match yours specifically, and we build that out with you during your implementation. Another fantastic feature or noteworthy item about MyWay, you have the ability to customize the clinical content on the fly. I like to call that dynamic charting. A lot of other EHRs require that you utilize templates. You pull forward templates, you drill down through all sorts of folders and drop-down lists to pick the item you're looking for. In the case of MyWay, what if you can't find something? Well, in the template-driven world, you would have had to open up the template module and maintain those templates, and chances are you couldn't do that at the time that you're charting on a patient. That's not the case with MyWay. If you look here, I am on abdominal pain as my chief complaint. I'm on the category of quality. Now, say in this quality listing, I don't find what I'm looking for. I can simply select this quality link here. It will then open me up to choices where I can hit new, type in my value, hit OK, and I'm done. I've added that value in the library right then and there for me to use on a recurring basis. It's always going to be in my library until I pull it out or change it. That is something I can decide for just myself, my entire care team, or the entire practice. Something else that's also fantastic about this application, you have the ability to build or create user-specific treatment plans or protocols. We call them diagnosis associations. In this case, what you're looking at is where I've diagnosed a patient with vaginitis, and immediately it will expand out to the typical prescription that I will prescribe, a return visit in 2 weeks, and for the patient to stay off of caffeine. Now, these also will adapt based upon the different medications you may need to prescribe or different plans that you build out for different patients. The system will fold that into the batter for each provider. So providers, you each have your own opportunity to develop your own treatment plans, and they will auto-maintain themselves based on the variances that you use when you're charting your patients. Now, in this case, this is really just meant to show you the alternate methods that you can get data in the system. While you'll see me do a lot of pointing and clicking, I'd like to point out beforehand that you can easily freely type notes anywhere in the system that you have a free text field. You can also write notes out. If you're using a device such as what I'm demonstrating from today, which is a tablet PC, I can evoke the stylus writing tool, write my verbiage, my words. I hit convert. And this next screen, you'll see that it translated it to typewritten text for me. And something I'm not able to capture in a screenshot, you're also able to use voice recognition software. Dragon Medically Speaking might come to mind. It's a plug-and-play effort. There's no need to do any additional setup to be able to use voice recognition software with this application. And finally, if you want to continue using any level of dictation, there's an internal dictation system already built into MyWay as well. So let's go ahead and take a look at the end result, starting with some OB reports. This is an example of the summary report, 2 pages in length, and while this is not produced in the ACOG format, it has the exact same ACOG data elements. Okay, so we'll just quickly go through this so you can see what that report looks like. Of course, it grabs all of her history that you have. Okay, now again, this is just a sample of the summary report. There are many to choose from. Here's one of the EDD flow sheet. And we'll go ahead and make this bigger for you to see. Of course, if I had written any notes on any of the visits, those will appear for me here. Otherwise, it just populates and builds upon from one visit to the next. It does provide you your initial EDD, all the information that you'd normally capture on that ACOG form. Jumping down to page 2, it's just a continuation of the data that we've gathered over time. Okay, and finally, the comprehensive OB report. Equate this to the ACOG including Part D, which is that very long, multiple pages that fold out format. So this is absolutely everything. As you can see here, it's 11 pages in length. It includes the initial physical exam, entire medical history, the entire flow sheet, all allergies, meds, all lab results. All that is in here. So I'll quickly scroll through some of this. This is where we're gathering the physical exam or the initial physical exam information. Okay. Then we move on to the EDD, and this is the exact same report that you saw separated out that I just showed you prior to this one. What I'm showing you right now is all the reports for OB combined into one. There's her genetic screening. There's her lab order detail. Okay, and in the education forms that we might attach, it also notes that. Okay, and here's that summary again. And there's her past medical history. All right, now let's take a look at what an actual chart note looks like. Now again, I want to call out, you'll see me doing a lot of pointing and clicking. However, the end result will show something like this. It's where it's grammatical in format. It's in paragraph format as well. Notice that it writes out in nice complete sentences. Now this is the system's default record. It will always remain the system's default record. But as a practice, if you choose to have something else for your output, by all means you have the flexibility to create your own versions if you'd like. Maybe you would like to put your own prose, your own syntax, your own grammar in there. Maybe you don't agree with the way this looks. That's perfectly fine. Many practices do modify this to be whatever they choose it to be. Despite whatever choices you make, this will always remain the system's internal default record. Okay, notice here that it clearly outlines, draws your attention to the items that you actually selected or you documented on. Anything of abnormal value will actually show up in bold font for you, so it's easy to draw your eye to when you're reviewing a document such as this. Okay. Well, folks, I want to thank you for your patience while we got through that little orientation. Now let's get into the good stuff. Voila, welcome to Allscripts MyWay for OBGYN. What you see right here is your main login screen, also known as your desktop. As a user, you can design this based upon your own preference, or it can be designed based upon your role in the practice. Now, the view that you see right now, I've designed it with simplicity in mind, keeping doctors in mind. I know you guys like to keep things simple, don't like a lot of clutter, and especially moving into an EHR, you certainly don't want to log in and not know what the heck you need to do because it's too busy. So what you're looking at is simply my patient visits for today. I've configured this to have quick and easy access to any unfinished notes that might be in my office for today. It could be just today. It could be overall time. Maybe you still have notes from a couple of days ago that you want to review and sign off on. Well, those will be accessible to you here as well. And finally, my message center. Consider your message center like a tasking system. It works and behaves a lot like email. The difference is, as a user, you can tell the system how you want things to behave. How do you want tasks to be delivered to you? Or do you even want certain tasks to be delivered to you? Maybe only those of certain nature go to your supporting staff, where you receive only the urgent or the high priority ones. You can actually tell the system to do all of that for you, in particular where that involves labs. You can perform any of the actions directly from this screen. You do not have to dig in and open up a patient's record if you don't want to. Now, this is, of course, alerting you of all things that might need your attention, that's spanning your entire patient population, not just the patients that have an appointment today. This can also include such messages as your spouse has called, or there's a drug rep here, free lunch in the lunchroom. Now, in terms of actually taking a look at one of these cues, for example, let's take a look at our labs. And maybe we want to look at Diana Durant's urinalysis. We can simply open this up, and it will present to us the lab result values. Now, this is under the premise that this is being received from a lab through a bi-directional interface. And on that note, we do interface with most of the major labs out there. If you're considering interfacing with your local hospital, as long as your hospital is willing to meet HL7 standards, by all means, we can certainly do the bi-directional interface with them as well. This is very important when it comes to meaningful use when you have interfaces in place, because that allows you to receive the lab results as what's considered discrete data. That is a requirement of meaningful use. Now, you can also receive faxed lab results if you'd like to scan them in, attach the copy as the result. You can do that, but you would still need somebody to key in the results individually to get credit for meaningful use. Hence why a lab result interface is probably well worth the time and the money. Now, of course, I can see any abnormals here. If I want to approve this, mark it complete. I can easily attach my own notes or interpretation to this. I can task somebody in my office with this. If this lab result's bouncing back and forth between multiple people in my office, I can also see the recipient history and the action that they took. Again, all being able to be done from that one cue without having to dig open that patient's record. Now, we can cover more detail about this during the open Q&A session. At this moment in time, I'd like to go ahead and shift our focus over to our first clinical example. This would be Kaylee Corden. She's here for her 12-week visit, an OB follow-up. We see that she's in exam room 1, ready for the doctor. Doctors, you probably want to review her record prior to going into the room. This is the equivalent of pulling that paper record out of the door pocket and rifling through it. But in the paper world, you've got tabs in your chart that tell you where lab results reside, where that ACOG form you started is sitting, where her progress notes are. Well, in the case of MyWay, we provide you an electronic index instead, or a table of contents. Notice here that I can see the information type of what's summarized, and by means of a link, I can quickly jump to that information. Maybe I want to take a look at her medication history. Okay, I see that we've already prescribed her prenatal, and she used to be on ortho-tri prior to her pregnancy. I can quickly jump back up to the top. If I want to take a look at anything else that's pertinent, maybe her overall medical history, if any exists, it will be presented to me here. As a user, you have complete determination of what shows up or gets summarized in this sheet as well. You can simply add anything you'd like by changing your viewing options and checking any item in this grid that you want to have summarized. I can alpha sort them, or I can random sort them based upon my own pertinence level. And finally, this is how I get that index to show up for me. So naturally, you can turn off the index as well if you prefer to scroll through the record versus quickly jump to individual items. All right, at this point in time, if I'm going to take a look at any attachments she might have, we already have her ultrasound in here from 8 weeks. And by the way, if I wanted to annotate on this, I absolutely could. Just letting you know how you can get digital imagery into the application. You can attach anything that a device can output in any type of JPEG or bitmap or Microsoft Word document, something to that nature you can easily attach to their record. All right, so we're feeling pretty good about this. Let's go ahead and jump in and record that flow sheet information. Now, if Kaylee presented with any problems thus far in her pregnancy, I would simply go to the appropriate area and document that. You'll see how that flow works when I actually document on the problem visit. But considering this is a healthy pregnancy, you're just going to jump straight to the case management where you can capture the flow sheet data. In this case, it is alerting me her LMP, what's it based upon. If we did the initial ultrasound, what date, and of course that would alter the gestational age as well. And now we can jump to our flow sheet. Fundal height, we're not recording at this point in time. She's too early in her pregnancy. But we are recording it for fetus number 1. And fetal heart rate today we'll say is in the 172 range. Fetal movement, present or not, in this case it's too soon. If we did a cervix exam, dilation, effacement station, ultrasound, at this point in time, again, still too early in her pregnancy. We can document edema, we'll say negative. And in this case, trace elements of albumin or glucose in her blood. We also want to go ahead and get her on track and make sure we get her OB lab scheduled for her. In this case, I can simply select them. Well, if it'll stop sliding away from me, there we go. And what that does is allows me to document all OB labs that we would normally order for a patient in the first trimester. Okay, so with that said and done, we've got those ordered for her. If we had any other results come back, maybe we had sent her off for tests after her initial exam, we could see whatever results have come back in from the labs directly from this screen as well. Any other information? And by the way, if I want to increase my real estate, watch how quickly I can close that. But this is where we would gather any of that other information related to her domestic partner or husband, father of the baby, if not her husband, all that good information. This is also where you'd capture C-section information, whether it's scheduled, the anesthesiologist, the assistant, all of that typical stuff that you'd normally gather. And moving on to the summary, this is where it's going to present us all of our available OB reports. We're beginning this presentation. I actually showed you 3 of them, showed you the comprehensive, the flow sheet, and the summary format. But this is where you can break them out. Now, it's typically the summary and or the flow sheet and EDD reports that get sent to the hospital. That's always going to be dependent on you as individual practices and what your hospitals expect you to submit for labor and delivery. All right, you do have some flexibility to add free text notes in anywhere in this, as well as we do provide you notes fields within each of these areas as well. If any of that customization is required, we simply work with you on that during your implementation. So at this point in time, she's healthy. We'll go ahead if we want to make sure that she comes back. We've already got it set to come back in 4 weeks. We can close out our note. Mark it complete, and off we go. Notice it kicks me right back out to my appointment screen. Now we're free to move on and see our next patient, Donna Day. She's already in exam room 2, and she's ready for the doctor, and she's here with vaginal irritation. Once again, let's take a look at her record prior to walking in the room. Okay, at this point in time, let's take a look at her active problem list. Okay, she doesn't have any. She's in healthy shape. jump back to the top. We want to take a look at her vitals as taken for today. She was at 140 pounds today. And we can also see her last visit. She was at 142, so she's lost a couple pounds, good or bad. Doctor, you determine that. Any other area we'd like to investigate, again, this is where we can do so. Any attachments she's got to her record, we have visibility or access to them here as well. That can include past paper records that you scanned in as well. Let's go ahead and pick up that note right from where our medical assistant has left off. It brings me to my chief complaint tab, where I see she's here for vaginal irritation. Let's go ahead and gather some history on that. We'll say that it's itching and it's thick, worsening. We'll say that it was gradual in onset, and she noticed it about 4 days ago. Okay, if we want to document any severity, moderate maybe, frequency or length as needed, maybe we want to jump down to triggers. And we'll say that sexual activity seems to make it worse. Okay, anything making it worse or better, or sexual activity seems to trigger it with her, I should say, but anything making it worse or better, notice are my alleviating factors and exasperating factors. So in this case, we'll say warm bath helps her feel better, and activities make it worse, and tight jeans too. Now, if I needed to add any value to any of these columns, I can simply jump into my library and add that value on the fly as I see fit. My experience as a trainer in these applications, a lot of doctors did not know what they needed to modify in their systems till they were actually using it. And this is giving you that perfect platform to change things on the fly. Pertinent negatives and positives. She doesn't have any abdominal pain. She doesn't have any fever. Okay? She doesn't have any pelvic pain. However, she does have, this is where we'll say vaginal pruritus. There we go. Now moving on to the patient history. Now my medical assistant was kind enough to review all the past information and bring it forward. However, if I needed to review it, I can simply select whatever area I wanted to look at. I can also pull in the patient's medication history using the SureScripts network. Because of ePrescribe, I'm able to link out and see the medications that this patient may be on outside of what I have documented or what I've prescribed. Also, provided you have gained patient consent to do so, you can import that medication list into your application. That's called medication reconciliation according to Meaningful Use Guidelines. Medical history, if you want to review that. Okay, we see that she did have some abdominal pain in the past, but notice it's inactive status. So it's part of her problem list. It's just not part of her current or active problem list. And, of course, if she had any family history of an, oh, by the way, I forgot to tell you that on my paternal side there's some cancer, well, then I can document that, modify that as needed. This is also the area for any brand new patients where you would gather that initial family, past medical, social history. We also have the ability to have the patient input this information via means of a patient portal where the practice can review that information and accept it into the system as opposed to having to go through these steps. So let's move on over to our review system. In this case, we review everything and all is normal for her with the exception of the genitourinary area. This is where we can document that she does complain of genital problems. She does have vaginal discharge and irritation, no pelvic pain, and no urinary problems. Now notice that some of my buttons are already preset with values. That just means I've set my system up with defaults, meaning you as a user can do the same thing. You can all have your own default set, and you can even change the symptom list up, whether it's in order or actual descriptions themselves. A lot of practices actually group their top 10 symptoms that they check on towards the top. Set the defaults in there, what they normally would be 90% of the time, then leaving everything else down below as NAs, allowing them to document as needed or as one-offs. Okay, we're going to go ahead and get nocturia out of there as well. Now moving on to our physical exam. I do have all my physical exam types available for viewing today. The application does come with all of them, and knowing that OB-GYNs often act as a female's primary care provider, you may need to utilize any one of these at any given time. You could turn them off if necessary as well, so you don't have them in your view if you never need them. Furthermore, you can create your own physical exam types as well. Maybe they're problem-based. You can easily create them, and just like in review of systems, select that everything is normal for that type of problem, and then chart by exception for the patient. Let's go ahead and keep this one problem-focused, starting with constitutional. We'll say that, generally speaking, Dawn is of normal, healthy appearance. if she was not. If in the nourishment area maybe she was on the obese side or the heavy side, we can document that. And what the heck? I don't see the word heavy in here because I don't like the word obese. Well, look at this. I can add it on the fly. I've said it a few times, so why not show you guys, right? And I'll alpha sort that because that's the way my brain works. And I close it out, just prompts me that I changed something, and there it is. Heavy has now been added on the fly. Let's go ahead and go down and check her abdomen area, make sure everything's good there. Everything feels normal to her, and that's all I'm doing, folks. I'm selecting my normal values. By default, the system is delivered with clinical norms, but again, you can change them to normal abnormals based upon problems. Now to the genital urinary area. We'll go straight to the vagina, and we'll definitely say that vaginal discharge is scant, okay? Maybe a little bit malodorous. All right, and maybe she's got, we'll say it's an erythematous vagina and vaginal tone. We'll go ahead and say normal exam. So based on physical exam and review systems, we're pretty certain at this point in time that she's got a good old yeast infection, a.k.a. vaginitis. And just as I showed you prior to coming to this application, I've got a treatment plan built around this. I'm in agreement with all of that. I can select it all. And that literally completes my note for today. Evidence of that, if I stop off of my prescription tab, you can see that my prescription auto-populated for me here. It will automatically e-prescribe to Walmart for me. And on the note of e-prescribing, we do provide you with the SureScripts file that includes all the pharmacies that are registered with them. At time of patient demographics, you can attach as many pharmacies to each patient based upon the ones that they frequent, allowing the physician to have that dialogue, which pharmacy are you going today, if it's not just one that they go to. Or furthermore, like in the case of myself, I'm usually squeezing in doctor's appointments on my way to the airport before I fly out on business. I usually don't have time to stop off at my local pharmacy, so I've asked my provider before to e-prescribe me to the state that I was landing in, near the airport. He's been able to do that, and I was able to pick up my prescription once I landed. It was very convenient and very efficient for everybody. I can also manage any other medications if I hadn't done so on the patient's history tab. And just like on the patient's history tab, I can pull forward medications from outside of what we have documented. Any services I might have provided today, I didn't have any in my treatment plan, but if I did provide anything today, this is where I can choose from that list. It also behaves just like diagnosis and chief complaint, where it presents back to you your most frequently used services. Now, we do build this out to match your encounter form, and these are for any services that you're billing for today, that you performed them, you did them. Services ordered is the exact same concept, only for future orders or outside of your facility. That can include labs or maybe a procedure that a patient needs to come back for to your office in a future date. And that plan auto-populated because of that treatment plan I selected. My return visit in 2 weeks, I can change that now if I'd like to maybe 4 weeks, or as needed. There's my no caffeine. And if I felt that I needed to involve another provider in this patient's care, I simply attach them to this visit. From there, I can generate a consult findings letter or referral letter based upon my documentation of today's visit. Any patient instructions, I can either freely write, type, or I can create them on the fly or pull from a library of ones that I've already been using or pre-created for myself. For example, I do have one in here for vaginitis, saying to avoid a thermal scratch. Okay, and do not rub while toweling off, pat dry instead. If I had any other visit notes I'd like to add to that, these are the things that the person checking the patient out will see as somewhat of instructions or anything to remind the patient of. And finally, I've got internal notes. Internal notes are really reserved for a CYA or something you'd like to document about that patient. It's pertinent to their record, but it's not something you want the patient to see if they ever request a copy of their records. They can be things such as patients unruly, you suspect some psychosis, or maybe you suspect they're drug seeking. Any of those things that cover you medically, and however it's not alerting the patient that you've commented on that about them. Before we exit our note, I want to point out as well that you do have access to have any type of health maintenance rules you choose to follow in your practice. What you see up on the screen here are based on the CDC U.S. Preventative Task Force rules. I can simply action anything that we added to today's visit if we did, or this can alert me to contact our scheduling folks to make sure that we get this patient in here for any of that screening. I can attach education forms as well. The system does come pre-delivered with education forms based upon industry standard. However, as a practice, you are absolutely free to import your own or use your own as you see fit. As long as you can get them an electronic copy, it's just as simple as if I hit Add, instead of searching from the existing library and I hit New, notice how I can import from anywhere on my network or computer any file that you have for patient education, above and beyond what's already delivered. All right, folks, let's go ahead and wrap up our visit. Mark our note complete. But before we exit out, perhaps we'd like to see how we scored against D&M Guidelines 1997. Well, it does detail out for me that it's a detailed history I took and an expanded problem-focused physical exam. It also lets me know how many points I scored in each category. Notice that I can link or jump right back into the area of the note if I needed to add documentation. All it really requires of me right now is to provide it my level of complexity. In this case, we'll say it was low. It keeps it at a 3. We confirm that level of care. We can confirm it to whatever we see it is fit for. Perhaps we did dictation, or a lot of free text typing, or we used Dragon. There's no way this tool can score you on those things. So maybe this note is indeed a 4 or a 5. If you feel confident that it is, then you select that. This is not meant to be Big Brother. It's just a tool to help you come up with the accurate score. I'd also like to point out that you can score this note based on time as well. And finally, before we exit, I want to point out we do have a PQRI engine already pre-loaded in the application. If this was a Medicare patient we were dealing with, if I selected that tab, it would outline or present to me all the quality measurements that that patient qualified for. You can then select the things you did or did not do, or even use it as a checklist for preventative care, guidance, and quality of care, and it allows you to get that claims level reimbursement. You can select those items, and it will actually stamp on your claim the G and the J codes. All right, so confirming it at a level 3 allows us to finish our note. And by the way, if you've got any nurse practitioners or PAs in your office or any other clinical staff that might be doing documentation that needs to be forwarded on to you to supervise or sign off on, we do have that area right here for that to be captured and documented. All right, it's just queuing me up that there's my prescription. It's going to go off to ePrescribe as soon as I exit this note, and any lab orders that I'm interfaced with will also be generated to the lab facility upon me exiting that note. All right, at this point in time, Donna Day is now in a ready-to-discharge status. That does complete today's demonstration. I'm going to open up the lines now for open Q&A and turn it over to you.
All participants in your conference are now unmuted.
All right, everybody, the line should be open. The floor is yours.
Hi, I have a question about the treatment plans that are in place. Are they already pre-created, or that's something that we could tailor if we get with the system?
They are not pre-created whatsoever. Everything I showed you, I made up myself. So you create them based on your treatment plans, your physicians, what they typically prescribe. You can even start with national guidelines as your basis, but as prescriptions change or as physicians, maybe they're participating in clinical trials and they're biased towards using certain prescriptions over the other, absolutely it's tailored per user, and it will change per user.
Can I ask you, what in the system cannot be altered?
The logo, some of the coloring and some of the font size, and the tabs that you see the order in, what we call the full note composer, you cannot change the order of those or turn any of those off.
I'm sorry, what is that again?
The tabs that start off with the vitals, chief complaint, history of present illness, all of those tabs, you cannot change the order nor can you turn them off.
Okay. But everything else in the system can be altered?
For them, I won't say everything else. This is just what I'm coming off at the top of my head. But yes, you can change all the clinical contents. You can create your own treatment plans, which that's probably 90% of the system right there that you have the ability to customize or change. This desktop, of course, can be changed based upon user preference as well.
Okay, thank you.
What else? Goodness gracious. I know, I can tell it's Friday. Everybody's quiet and like, hurry up, finish. We want to go.
Hey, on the health maintenance alerts, those are something that you build into the system, correct?
That is correct. We do deliver it with a blank slate based upon our own history and practice with delivering applications with them already loaded. Our implementation staff would spend more time turning them off and modifying them than it was just to build from the ground up what you choose to follow.
Okay.
A lot of times, too, states have varied. I know Colorado for sure is an example of a state who does not follow the CDC U.S. Preventative Task Force rules. They've actually modified significantly as a state themselves. So it just makes more sense to say, hey, you've got the functionality, and you can follow whatever you want, whether it's preventative health rules or if it's clinical trial type things. Maybe you want to be triggered when patients qualify. That's a way for you to get extra revenue stream without having to do anything else. It's already polling your patient population for certain things. It's pretty cool. I just happened to demo with the CDC U.S. Preventive Task Force rules so that I can show you something.
I don't think I have any more questions.
No worries. It's okay. There's another one of these that I'm doing on Monday for OBGYN as well. So if for some reason you guys want to hop back on a second one, maybe you come up with questions later, that's fine. And we also do have one of these recorded as well. I don't know if it's been made publicly available on our public website just yet, but it is recorded, and soon we'll be able to have anybody who wants to hit a recording for OBGYN on our website, they can.
Is it available to partners?
It's available to partners, absolutely.
I have a question about e-scribing. You have a list of pharmacies that have contracted with Allscripts. Is that how it works? Like if there's, say, like I do a lot of diabetes prescribing, so I know like Better Living Now is something that I have to use for my hip patients. Can I just automatically get them connected with Allscripts if they have the technology, or is that like a more involved process than that?
And I'm not quite sure I understood. Who is it you want to get connected to Allscripts?
In terms of like e-scribing, there's a durable medical equipment called Better Living Now that I have to use for my hip patients.
Got it. Okay.
So is it easy to get a DME company or a pharmacy connected to Allscripts, or is it limited to who already you guys have like contracts with?
Anybody who wants to sign up, they can, but it's not signing up through Allscripts. They sign up through SureScripts. SureScripts is one of, I think, 2 or 3 of the largest organizations that do what they do. And so we contract with SureScripts. SureScripts is the hub we go through. And our e-prescribing platform connects to them and connects to all the pharmacies that are registered through SureScripts. So it's up to your DME organizations and individual pharmacies to get themselves registered with SureScripts. And then our e-prescribe platform hits SureScripts. Does that make sense?
Yes.
Okay. So it should be, I don't know that it's difficult. They just have to hit the SureScripts website, and there should be some instructions on how they can get registered. And as long as they're registered, our e-prescribe platform hits that. And even if on our end, your physician's prescribing or you're prescribing something, you don't even have to stop and think, is this a fax-only pharmacy? Is this mail order? As long as you e-prescribe it from the system, SureScripts will recognize if that pharmacy is a fax only or a mail order, and they will translate that for you. So you get credit for e-prescribing, but SureScripts does the rest of the thinking for you. And then for those of you who may not be aware, I think this is fantastic news because it stops the double workflow when it comes to prescribing and the whole e-prescribe world. Schedule 2 through 5, a.k.a. narcotics, have now been approved for e-prescribing. It will be implemented this summer. So the legislation's been approved and passed, and then the first pass-throughs or accepted ones will be happening this summer. So that, to me, is incredible. So physicians, you're no longer having to think, I have to send this one to the printer so that I can do my ink signature on it.
And renewals work the same way. So say if a patient calls, Mary Smith calls, she needs a renewal on her insulin, you could just go to her chart and do the renewal right through e-scribing, right?
You got it. A lot of practices, and I'm sorry if it sounds like I'm trying to tell you what the best practices are, but I'm finding out more and more practices are telling patients to request the referral from the pharmacy or the renewal from the pharmacy to keep it a little more streamlined. Because then that way the pharmacy can generate the request electronically to you. You just hit accept. It goes right back to them and they can refill it. At least that's what I know my physicians have even told me. They're starting to do that now. When I call my practice to ask for example, a refill on my birth control, my practice is now telling me, please call your pharmacist and they'll contact us.
So that would come up on your email?
It will come through for any type of ERX refill request. They'll come through in this queue somewhere. Gets its own. It will be separated from the actual refill request where a patient's called the office, because it's going to be some time to wean or educate your patients to go through the pharmacist versus you, and it doesn't mean you have to turn them away. I'm just letting you know what I'm hearing is happening out there. Now, refill requests here that I have loaded here are really from the practice or from the patient calling the practice saying, I want a refill request.
Thank you.
So as long as the refill they're requesting was originally done through ePrescribe, it still will be ePrescribed or e-refilled or renewed. I think it's just more workflow of getting it streamlined to where you're always just dealing with the pharmacy versus the patient. All right, what else out there?
I'm a reseller, and I have to say I'm not as familiar with some of the terminology for OBGYN.
Mm-hmm.
The stuff you said today is the first time I've heard that.
Well, do you have any females in your life that see one of them?
Yes.
Then if my best suggestion to you is actually ask your whoever that person is. I don't want to assume it's your wife, girlfriend, daughter, mother. Ask them what some of these terms mean, or you can easily do some Googling or researching.
Oh, not those terms.
I
mean, more of the medical reporting terms that you use.
ACOG?
Yes.
For any obstetrician currently on the line right now, they know what ACOG is.
Yeah, but I don't as well.
It's the American College of Obstetrics and Gynecology.
Okay. Is there anywhere in our literature that I can read up on that?
ACOG. Type that into your Google search and you'll get plenty of information.
ACOG.
Mm-hmm.
Okay.
Yeah. Every specialty out there has their own academy or their own organization. ACOG is the one that represents obstetrics and gynecology. That's exactly what ACOG stands for. American College of Obstetrics and Gynecology, hence the term ACOG form, and that is something that's been utilized for probably close to 40, maybe a little longer, years now. So again, I encourage you Google for those partners on our phone who would like more information on that stuff. Google will be your best friend. All right, is there anything else I can answer for anybody? I do recognize each practice is going to have a variety of workflows we may not have touched on, but the goal of today's presentation is really more or less, can you use this in your office? Does it look easy to use, adaptable enough for you? And, of course, if there is one of those workflows I didn't cover, now would be a fantastic time for you to ask if we can do it. All right, right. Well, you guys, thank you so much for your time. Happy Friday. And maybe I'll encounter some of you on a future webinar. Have a great afternoon.
Thank you.
Bye, everybody.